So, hi everyone, my name is Molly Blafer. I am a program manager at AUCD. Thank you for choosing to join us in this breakout room, which is primary care services and community-based lifestyle. We have a faculty facilitator, Calliope Ho Ling, who will be facilitating us through these sessions. As a reminder, the breakouts for each poster are 15 minutes. I will show you that you have about 1 minute left by pulling up a screen that says so. So I will override share just so you know you're running out of time. And for presenters, just remember the 15 minutes includes time for Q&A. So I will give you a time update at around 7 minutes to let you know if you want to switch. So that being said, I will pass it over to Calliope.
Wonderful. Thank you so much, Molly. And thank you everyone for being here. I'm really looking forward to this set of presentations and to an engaging discussion. So as Molly said, we're going to have 4 different presenters and I'll introduce each one of them. The first one will be, so sorry about that. The first one will be Benjamin Jaffe Schindel from Kennedy Krieger Institute, followed by Marilyn Taylor from Nova Southeastern University. Third, we'll have Aidan Gagnon from University of Alberta. And last but not least, we'll have Alexandra Newson. So let's begin with Dr. Benjamin Jaffe Schindel. Benjamin, I will let you go ahead and share your slides. And then once you wrap up, we'll leave some time for questions and discussions. And folks, feel free to come off mute or put some questions in the chat.
Sure. Okay. Hi, everybody. So I'm going to do the classic Zoom thing here and check to make sure that everybody can see my screen.
Yes, we can see it. Thank you.
Wonderful. Well, it's such a pleasure to be here. My name is Benjamin Schindel. I am a physician and a public health researcher over at the Kennedy Krieger Institute and Johns Hopkins in Baltimore, Maryland. And I'm here to talk about my project, which I call Age of Autism Spectrum Disorder Diagnosis in a Nationally Representative Sample. So we all know how common autism is. The average age of diagnosis ranges from 4 to about 7 years old in the United States. And there are a lot of factors that are known in the literature to be associated with that age of diagnosis. One of the factors that receives less attention in the literature has to do with just how difficult autism is to diagnose in older children and adolescents. And one of the reasons that I'd like to highlight here is the dearth of screening tools that we have for use in later childhood and adolescence. So this image here is showing the screening tools that are recommended by the AAP. And it's a little bit of a blurry image. I do apologize for that. But the autism spectrum disorder screening and the general developmental screenings end at 30 months of age, which means that there are no screenings for older children recommended by the AAP. So what I wanted to do was describe the patterns in the, this is a description of that previous image. So my objective was to describe patterns in the age of autism diagnosis, with an expectation that we'd probably see more diagnoses in early childhood compared with adolescence. There would be some significant influences of known sociodemographic factors. And that was, sort of how I was coming to this. So I used the National Survey of Children's Health. This is an annual household survey. A parent or caregiver will answer the surveys on behalf of one of the children living in their homes. This is a survey that's run by the U.S. Census Bureau. In our sample, we restricted to children and adolescents who were 3 to 17 years of age. And we looked at the age at which autism was diagnosed and also looked at some of the demographic factors that might have influenced the age of diagnosis. Nope. Right. So again, the way that it worked was the parents were responding on behalf of their children, or on behalf of the children in the household. One thing that was kind of significant that I want to point out here is that in the data sets that are available through the NSCH website, the age of autism diagnosis is asked specifically, but it's coded as an integer value. So 1, 2, 3, all the way up to 14. And then for anybody who was diagnosed at 15 years or older, they're kind of lumped together into one group. So what that meant was that it was going to limit the ability to look at that oldest age group in detail. Instead, the way that we wound up compensating for that was by grouping the 15 to 17-year-olds together. And then those who'd completed the survey at 15 to 17 years old, and then sort of looking at their answers retrospectively. And I'll show you what I mean by that in a little bit. So in the end, we had over 100,000 individuals. About 3% of the sample had diagnoses of autism, which is consistent with national prevalence estimates from that timeline. And in the whole sample, the median age of diagnosis was 5 years. So when we plot this here is showing a graph of the age at which the age of the child at the time of survey completion on the x-axis and the age of diagnosis on the y-axis. The kind of main takeaway here is just how flat that line is. So what this is telling us is that for pretty much every age at which the child was, from pretty much every age of the child at the time of survey completion, the age of autism diagnosis was between like 4 and 6 years old, about. Again, the description of that. We also found that far more children were diagnosed in early childhood compared with adolescents. Oh, sorry, this is looking at the proportion of ages of autism diagnoses, and you can see these peaks early on, and then it really tapers off after about 6 years. We also saw that some demographics were disproportionately represented, which I will show here. So male sex, non-Hispanic white individuals, respondents with college or higher educational levels in the households, and English-speaking households, again, were overrepresented. We also, I forgot to mention this earlier, but one of the things that we were able to look at here had to do with the source of the diagnosis, which included non-school psychologists, psychiatrists, primary care providers. We found that non-school psychologists and psychiatrists were more likely to diagnose autism in adolescents compared with early childhood. But that kind of makes sense because they're generally more likely to be seeing children in adolescence compared with early childhood. So we know that there are a lot of sociodemographic factors that influence the age at which autism is diagnosed. And I think that some of these could point to potential opportunities to improve access to diagnosis and to care. But also, I think that these findings might be suggesting that there are some misdiagnoses of autism happening in later childhood and adolescence, which are when we don't have screening tools and the symptoms change. In other words, I think that we're missing opportunities to diagnose. These are findings that I think can help to support the argument that we need greater identification practices for older children and adolescents. And this can occur throughout it can occur through educational outreach, through developing new screening tools, training primary care providers, or training teachers and other individuals who are in direct contact with adolescents, sort of what the manifestations may be. I do suspect that there will be a number of challenges with this, including just the structural problems that are inherent in these gross health inequities, as well as barriers to things like accessing schools and IEPs, considering which symptoms are impairing versus not, which is one of the barriers that a lot of schools use when they're making these diagnoses and providing services. But I do think that a national estimate of when diagnoses are occurring and how that distribution changes with age could sort of help to inform greater practices moving forward. So kind of flying through this, but I do appreciate your time. I've included my email address here for anybody who wants to reach out to me after the fact. And I look forward to questions and conversation. Thank you.
Thank you, Dr. Schindel. We really appreciate you sharing your work with us. Let me go ahead and open it up for questions and discussion. What questions do you have? Again, feel free to come off mute or to put them in the chat if that's better for you. Yes, while folks are thinking up, I can ask a couple of mine.
Sure.
Were there any sort of correlates that you weren't expecting in terms of sort of who was represented in the data and what was associated with age at diagnosis?
There were not so many of the findings that we had here were actually expected because they kind of did fall in line with what we would see in sort of national estimates in the previous literature. But some of the things that I thought were sort of the most surprising, there were a few actually. So one is just how flat this curve is. And I think this was the one that I really was kind of most interested in, because my suspicion is that many people who have autism and could benefit from services and interventions are existing in this group where they should be diagnosed later on. I think that this graph is representative of poor identification and diagnosis later rather than improved identification in early ages. The other one that stood out to me was the factors that were associated with greater diagnosis in adolescence. So some of these were expected. We know that boys tend to be diagnosed younger, females tend to be diagnosed later. We also know that there are some racial and ethnic disparities in the age at which diagnosis occurs. But some of the distributions of household education levels and the ways that those correlated with diagnosis in early childhood versus adolescent were somewhat unexpected. And I think the Spanish-speaking households, that finding probably requires a closer look because we know that the vast majority of the sample was English-speaking.
Hmm. Thank you. That's really helpful. Any questions or comments at this point? I can ask my next question. Well, I encourage folks to yeah share what sort of thoughts and questions you have. Dr. Schindel, my question is, I feel like we hear sort of these type of results quite a bit in terms of, we're aware of these gaps. We need better screening. We need better services. Access is limited. Do you have any thoughts on really the concrete next steps that we could take as a research community to moving this forward?
I really think the most important next steps would have to do with the so what element. So we're diagnosing, we're likely missing a lot of individuals with diagnoses of autism that are a little more subtle when we're not screening for them in later childhood and adolescence. Well, so what? Well, I think that we know that people who have autism, who have all sorts of developmental disabilities, benefit from having interventions and having supports in place. And the absence of those interventions and supports are associated with quite a few longer-term health and socioeconomic outcomes that I think we can address. I think this is really a population that improving the care and improving the support that we can provide kind of has to start from the beginning, which is identifying this population in the first place.
Gotcha. And would you say there are no screeners available at all for these older children with autism or adolescents? Or is it that they just haven't really been validated and therefore they're not sort of recommended on a population level?
There are a number of screeners for primarily for other developmental disabilities, things like learning disorders and things like that, that are validated through adolescence and early childhood. There's one from Colorado. But in terms of screening tools for autism that are really, validated and useful for older children and adolescents and even young adults, there really aren't any that I'm familiar, or certainly none that are used on a broad or can be recommended for use on a broad scale.
Sure. Okay. Thank you. I'll take another moment here to see if anyone has any questions. Oh, so Charlene is asking in the chat, building on the previous question, are there any policy implications for these results?
Thank you for that question. I sure hope so, because my suspicion is that if we can improve the way that we identify that we identify individuals with developmental disabilities who kind of slipped through the cracks until later childhood or adolescence, we can really improve the outcomes for them. And I think that the way that we do that is sort of similar to the way that the early identification movement was rolled out, which is to say that it was sort of incorporated into American Academy of Pediatrics screening recommendations and was very, very effective in increasing the identification of younger children with disabilities. So I think a similar model would be beneficial here.
Thanks for your question, Dr. Choi, and for that helpful answer. I'm still looking to see if anyone else has other thoughts, but I'm curious sort of what you envision as the next steps for this research for you personally. Like where are you sort of taking this forward?
Sure. Yeah. So the truth is that I'm actually kind of calling it quits on this this stream of research at this point because I'm running into that question about so what. And I think that until we can make the argument that there's a huge benefit to identifying and providing supports for the people who've slipped through the cracks, we're not going to be able to make any movement on that. So my sort of career trajectory is going to be looking at suicide and suicidal thoughts and behaviors in individuals with disabilities, with the hypothesis that people who have developmental disabilities without adequate supports or are not identified as having disabilities are at higher risk for suicidal thoughts and behaviors. And that's kind of one of the ways that I'm hoping to approach the so what element to the patterns of diagnosis and identification here.
Wonderful. Thank you so much for sharing, and we hope you can come back and share that work with this group sometime.
I look forward to it. Thank you so much for your time and attention today.
Thank you. All right, so I think we will go ahead and move on to our next speaker. Our next speaker is Marilyn Taylor from Nova Southeastern University. And this project is titled Parental Perception of Females Diagnosed with ASD in a Pediatric Dental Clinic Compared to the Current Literature. Marilyn, the floor is all yours.
Hey, hi everyone. I just want to confirm that everyone can see our screen.
Yep.
Okay. So my name is Marilyn Taylor. I am currently a behavioral analyst and a first-year Doctor of Occupational student at Nova Southeastern University, and I'm joined by my colleague.
Hi, I'm Crystal. I am a dental assistant as well as a Master of Public Health student at Nova.
All right, and we'll get started. So for today, our presentation aims are an introduction, an overview of our grant and training program, and then also the current study, the methods, the results, and the conclusions to our project. So as Dr. Shendel previously mentioned about autism, 1 in every 36 children are diagnosed with autism. And then in comparison, females to males, females are currently 4 to 1 for the ratio. They tend to go underdiagnosed and can present with higher levels of social impairments in comparison to males that are diagnosed with autism. What we also know is that children and adolescents with ASD and related special health care needs tend to lack access to quality oral health care, which is what we're very passionate about here at our dental clinic. So the overview of our training program is that we are a HRSA funded clinic, which sees patients on a monthly basis to aim to desensitize these kids to the dental setting. Data for our study was drawn from this program that aims at training pediatric dentistry residents for the care and treatment of children with special health care needs. We have a pediatric dentist, a pediatric dental resident, and myself, the ABA therapist, as part of our staff. And then the purpose of this study was to increase the awareness and to promote oral health care practices aimed towards the ASD female population in a pediatric community-based dental clinic. The Mailman Siegel Dental Clinic is a HRSA-funded clinic that provides free monthly recare visits to children diagnosed with ASD under the age of 10 for the purposes of desensitization. We gather data from the new Mailman Siegel Clinic patients from the last 2 years that were selected to compare data points to the recent literature that would suggest an increase to females diagnosed with ASD. It is reported that these females also demonstrate higher severity in social impairments and challenging behaviors. So our methods, as we previously stated, we have our caregivers fill out what we call a pre-treatment assessment form. So that gathers demographic information and data related to the patient's comorbidities, their behavior, their communication style, their dental hygiene, their dental treatment history, and any current treatment needs. It also includes some of their behavioral needs and levels as well. We were able to gather a number of 85, and then chi-square tests were calculated to examine potential differences between our female and male patients. Our IRB review status was exempt.
So with our results, we only had one thing that came up as statistically significant, which was the speech delay within the males. So yes, as per the literature, our patient populations were 83% male and 17% female, and the majority of our patients had a confirmed diagnosis of autism spectrum disorder. And the most commonly co-occurring disorder was speech delay at 48% for both genders. Most caregivers reported mild to moderate behaviors at 81% and occurring at 1 to 2 times each day. 31% reported that their children were verbal, and the pre-treatment assessment form, the routine exam was the #1 priority, a cleaning, and then 53% of them had already visited another dentist prior to visiting our clinic. So here's the numbers right here. There's our significant findings right here, the speech delay. So here it seems again, parents reported the speech delay diagnosis. So with the results, that the males receive their diagnosis tend to be earlier than females due to their more outward expression of speech delay, and younger males and higher prevalence in social masking within the females with ASD diagnosis. And currently is it important for all patients to find and for providers to become more educated upon the current literature and presentation findings of females within this population. Let's see, we should also note that this is an extremely small sample size. Our clinic is very small, so our number is there. Further research is much more needed on a larger scale and should be performed prior to more sweeping generalizations for our findings. So, the impact of the studies to contribute to the ongoing research and understanding how autism spectrum disorder manifests differently in boys and girls, which can influence a wide range of health and educational services provided. Here's some of our references. And this is a HRSA grant, as we spoke earlier. Thank you so much.
Thank you so much, Marilyn and Crystal. Really appreciate it. And sorry again, Crystal, for omitting you in the introduction. I was just looking at the first name in front of me.
Quite all right.
Both for that wonderful presentation. Let me go ahead and open it up to any questions and comments from folks who are tuning in. While people are thinking of questions, I'd love to hear a little bit more detail about, as clinicians yourselves, how you adapt this dental practice to accommodate dental patients with autism. What accommodations do you create? What is sort of the desensitization process like? Are there any changes in the environment? Would you talk through that a little bit?
Yeah, of course. So we have catered our dental clinic to be very specific to autism because of the fact that our children need a diagnosis of autism to be seen by us. So what we talked about in our presentation with the pre-treatment assessment form kind of gives us an overview of what the child is according to the parent, because it's two different things, what the parent reports versus what we experience with the child as well. So what we'll do is we'll have the first appointment kind of dedicated to getting to know the child and seeing what we can present to them in terms of the typical dental visit, like the dental mirror, the toothbrush, the suction, the floss, and the fluoride, and see how the patient reacts and kind of cater to those needs after the fact. We try to make everything as friendly as possible as well. One of our doctors on staff has been here since the beginning of the grant 14 years ago, and he has kind of made a switch on all the names. So our suction is Mr. Thirsty, our floss is Mr. Shaky. So we kind of try to make it as fun as possible for these children as well. We're very accommodating for nearly every single kind of behavioral need. We have headphones that kind of noise canceling headphones for the suction if it's too loud. We have a TV and prioritize music and videos if that's what the child really gets reinforced by. So every month also allows us to kind of not have to push so hard in each appointment. So the first appointment might only be dedicated to having the patient sit in the dental chair. And then the next appointment is when we're trying to have the suction be placed in their mouth. We'll start off slowly and small seconds at first, and then build our way up until they're able to have a normal dental visit, just like a typical appointment.
Yeah, like she said, we have some specialized tools and accommodations. I currently have about 6 different flavors of toothpaste and probably 7 different flavors of fluoride and a couple that are unflavored. We try to find what works for each patient individually, and it's kind of cute sometimes when you read the patient notes because it'll be like, do not sing, count only. And we've had, residents that, just kind of read through the note too fast and they start, singing, and the kids like looking at it like, do not sing to me. And so we try to, make it as tailored as possible for their benefit in the long run.
That's great. Thank you so much for sharing. That just sounds like an amazing clinic, and they're very lucky to have you and the rest of your team there. I'll take a pause here to just see if there are any other comments or questions from people before I sort of move to my next couple comments and questions. Okay. The next thing I was going to ask is, I'm sort of not familiar with the literature on dental health and dental hygiene in autistic individuals. And I'm wondering, can you sort of let us know, is there a lot of literature? I mean, I imagine there's probably not a ton of research, but sort of what does the research to date show? And how does your study sort of fit into it?
So what the literature currently shows is that patients with autism special health care needs are going untreated almost. And it's very evident in our clinic as well. A lot of our patients who have previous experience in other dental offices here, the dentist will hear that they have autism and automatically just shy them away, regardless of their cooperation. We have some children here who have a diagnosis of autism and are very compliant and can sit through a dental cleaning without a problem. But just because of their diagnosis, they're being shied away from a regular office. Just because a lot of the literature shows that a lot of dental practitioners are not necessarily invested because they are, first of all, not taking Medicaid patients is a big one. And then the second one is that they don't feel adequately trained to deal with patients with autism or special health care needs. So our grant overall really focuses on that, on kind of teaching pediatric dentists to be well trained enough to feel confident and put them out into the world and be able to treat patients with autism and special health care needs. But we were just interested in seeing how the females who are currently they get diagnosed later on in life, and we only see up until age 10. We wanted to see if our population of patients had the same sort of numbers, because a lot of females are also going underdiagnosed because of their behaviors.
Thank you so much. Such important work. We're going to transition in just a minute to the next presenter, but I just want to give another opportunity for anyone to ask this team some questions or share any thoughts that you might be having.
Well, should you have any questions, both of our emails are on there. Feel free if after the conference you guys have any further questions. We love what we do and we're very passionate about it, so feel free to reach out.
Yeah, don't be shy. If you want more dental questions, you can email me. If you want the behavior questions, email Marilyn. If we don't know the answer, we will find somebody who does. We have a great team, like all the way up through. So please don't be shy. I know it's kind of like a very niche topic.
No, it's awesome. Thank you. Thank you both so much for being generous with your future time. I was going to ask if there's like a website or a resource that you could direct people to if they wanted to sort of learn a little bit more about this clinic, but it sounds like maybe just reaching out to you is the best way to go. Yeah.
Would be true, yeah.
Okay. Yeah, thank you.
Yeah, it's for a grant. So people, when we put the information out before, like everybody tried to come, they're like, "Oh, you're a free dental clinic." I'm like, kinda. So.
All right.
Thank you.
Thank you. Really
Thanks so
appreciate
much.
it. All right. So our next speaker is Adon Gagnon from University of Alberta. And I believe they may be joined by Emma Derwowitz. I apologize. I looked on how to pronounce her names beforehand and it's promptly fallen out of my brain. So my apologies, but welcome to both of you. Their presentation is exploring camouflaging experiences of autistic women through the lens of impression management, preliminary findings. So Adon and Emma, I'll go ahead and give you both the floor.
Sweet. Sorry, I have to do that thing. Can everyone see my screen?
Yes, we can. Thank you.
Okay, perfect. Hello, my name is Adon Gagnon. I am a white male of European descent with short red hair and a red beard. I'm wearing a blue shirt and I have 2 immediate autistic family members.
My name is Emma Derwowitz. I'm a white woman of European descent with long blonde hair, wearing a white top. We're both recent graduates of the University of Alberta and non-autistic allies of the autism community. Joining you from Treaty 6 territory, the traditional meeting ground of the Cree, Dene, Saulteaux, Nakota Sioux, Blackfoot, and Métis. And today we're going to discuss impression management.
Camouflaging keeps me safe. It's the curtain between my autistic self and my public self. That's what one of our autistic participants shared when being interviewed about her experience with camouflaging or impression management. Impression management is something that everyone does to present themselves favorably to others. We do it at job interviews, when meeting someone new, or when presenting at a conference. However, for autistic adults, it can be constant. As one participant said, "I always camouflage. I don't think it's ever 100% not there." Autistic camouflaging or masking refers to the suppression of autistic traits, mimicking the behaviors, emotions, and expressions of non-autistic peers, and engaging in continuous self-monitoring. Our research aims to validate a new framework integrating impression management with autistic camouflaging. We used framework analysis to perform a secondary investigation using 8 interview transcripts about camouflaging with Canadian autistic women.
Before we dive into our findings, I want to highlight a major achievement, the active participation of autistic community partners in our research. This partnership reflects our commitment to collaboration between researchers and the community, which is central to our philosophy and enhances the relevance of our work. Team members such as Nat Redwolf Pogue, Chris Bendivis, and Christina Devlin play crucial roles in ensuring that autistic perspectives significantly impact the direction of our research. And to reach a broad audience, we will share our findings through traditional academic channels and innovative accessible formats like plain language summaries, visual infographics, and interactive presentations, ensuring that academic and non-academic audiences can engage with their work easily.
Now to discuss our results. Most common motivations to engage in impression management were the desire to fit in and to mitigate stigma and harm. Our participants frequently used impression management to avoid unfair judgments from non-autistic people, with one participant sharing that others often assumed she lacked literacy, intelligence, or a range of other skills because of common autistic behaviors like stimming or her unique autistic communication style. However, there were 3 key motivators for not using impression management. 1, when they felt pride in their autistic identity. 2, when they were in a safe space, often with other neurodivergent individuals. And 3, to increase visibility and neurodivergence and alter people's perceptions about autism.
Our findings about the consequences of impression management highlight an unfair double bind that autistic people often face. Whether they decide to conceal their true autistic identity or unmask and reveal their genuine autistic self, they face many similar negative outcomes like anxiety, unfair judgments from others, and loss of social or vocational opportunities. One participant demonstrates this idea when she describes how forcing herself to make eye contact increases her anxiety because it feels unnatural to her. But at the same time, she explains that if she isn't using impression management, she would be, quote, anxious for not camouflaging and not appearing like I'm fitting in, like a neurotypical. It's like autistic people can't win. They feel anxious if they do and anxious if they don't. However, participants shared that certain environments can mitigate some of these negative outcomes. Our results illustrate the importance of a safe and accepting environment for autistic people. This allows individuals to refrain from using impression management, resulting in feelings of authenticity, safety, reduced stress, and acceptance from those around them. The experiences shared by our participants underscore the need for societal transformation that embraces autism as a distinct and valuable neurotype rather than a collection of deficits, a shift towards a world where autistic individuals feel safe to express their authentic selves. To conclude, I can't say it any better than one of our participants reflecting on what her life would be like if she did not use impression management. She shared, I definitely would not be living the life I'm living today. And that's strictly because of other people's perception of autism, because of the way people see autism almost as a burden. So no, I would not be where I am today. But I think if everybody were more accepting, it would be completely different. Thank you.
Thank you, Emma, and thank you, Aiden. Really appreciate both of you for sharing this really important topic with us. Let me go ahead and open it up for questions and discussion. Would love some brave souls to speak up or put something in the chat if you're open to it. Heather, thank you so much. Go ahead.
Hey, sorry, I'm here on behalf of Heather, but great job, Emma and Aiden. I was just wondering, because you're looking at autistic women, did that sort of identity component come up in any of the data that you guys looked at?
it's been a little hot second since I've looked at the data. But I do believe it did come up a few times in regards to especially that delayed diagnosis, which were kind of touched on by some of the other presenters, and just sort of that taking more time to sort of figure out what is autism and understanding what autism looks like as opposed to the stereotypical male presentation of autism.
Yeah, I do think a lot of our participants discussed, especially in childhood, not having an autism diagnosis and not really understanding why they felt different than other people. And I think that it's really interesting to learn about all of their different masking strategies and everything that came along with that, because obviously we do know that autism both presents differently in males and females, and then often females are also diagnosed quite later. So I do think that that had an impact on our research, but I think it might be a bit too early to say exactly anything specific about it. But yeah, thank you, Helen.
Thank you both. I'm going to read the question from Evan in the chat first, and then we'll go to Benjamin. Evan asks, what would you recommend to make the larger community more accepting?
I mean, some of the tangible ones were talked about, which was safe environments. So either if that's creating spaces where there's not that stigma around engaging in those like stimming, and sort of finding those places, but also sort of reducing areas. I know one participant strongly talked about, how there were certain places in their work where they would go to and just be able to like decompress. And so having these spaces where you can take this time. And then the biggest one though is again that acceptance and educating people on autism, what it looks like. And that person who's stimming in the corner isn't on drugs. They're not anything wrong. There's nothing wrong with them. It's just that's how they take in the world around them. And so that educational piece is probably the biggest one, I would say.
Thank you so much. Really appreciate that. Benjamin, go ahead.
Great, thanks. This was a really interesting topic, and for what it's worth, I was sort of particularly keyed in because I think there's some overlap with what I was talking about. And in that vein, I wanted to ask you one of the questions that was asked of me, which is how would you sort of imagine next steps? So my background's in medicine, so I'm kind of thinking as a clinician and as a pediatrician, but how would you sort of take what you're learning into practice and addressing this problem?
I do think that one big component of it is education. I know that some people in our lab or who interact with our lab talk about how important it is to educate everyone from teachers to clinicians about autism, how spaces can be more autism friendly, just how to serve the autistic population, things like that. Aiden, do you have anything to add here?
Yeah, I was going to say just like the practical steps, which is the big, again, that education piece, I think is a big thing that our lab focuses on and trying to make information regarding autism accessible and understandable and sort of getting away from those stereotypes that people have of, that either that like savant who knows everything but is socially inept, or to understanding, hey, autism, you interact with autistic people, like it's 1 in 34 of the people around you are autistic. And so everyone has different spectrum of needs, and how do we support that?
Great, thank you.
Thanks.
Yeah, great question. Thank you both.
Mm-hmm.
Any other questions from the audience or comments or just anything anybody wants to share at this point? Okay. One thing I was wondering about a little, I know there's this can be, yeah, I echo Tony's comment. Thank you so much for sharing this great project. Did any participants sort of share any sort of benefits, for lack of a better word, of impression management? And like, did you happen to look at how that was associated with sort of intersecting identities? Does that question make sense?
Yeah. I know that's one of the weaknesses, I think, in our preliminary analysis is that we've only been able to analyze from women. So obviously there's that sort of intersectionality between autism and gender identity, but we haven't done anything beyond that, and we have some of that data, we just haven't gotten around to it, because qualitative analysis takes a hot minute. So we're working on getting through that, and I think we'll be able to have some more interesting results once we have some more of those non-binary individuals, and sort of looking at the sexuality piece as well. Hasn't been something we've touched on too much.
Great.
And then
Yep.
also,
Okay.
just with respect to the first half of your question, if I understood you correctly, you were saying, are there also benefits to using impression management? Did they discuss any benefits? And we definitely do have a lot of benefits that our participants discussed about. Like, obviously, you use impression management for a reason. It's a purpose. And participants had a lot of different reasons for using it. So things like safety, just one participant said, camouflaging keeps us safe. It's the curtain between my autistic self and my public self. So there were many different reasons for using it, both reasons for using impression management and then positive and negative consequences for doing so.
Yeah, a big theme was also vocation, and a lot of people felt that they wouldn't be able to get the careers, they wouldn't be able to do the education or whatever without camouflaging.
Great, thank you. Yeah, Evan was asking, or Evan, sorry, what differences do you see in impression management between verbal and nonverbal participants? Is that something that you've looked at this point, or also sort of something on the horizon?
That would be in the next steps category, is looking at like nonverbal. It was interviews done during the pandemic, so unfortunately it was only verbal individuals.
Okay. And then Aaron, oh, sorry, Emma, I cut you off.
Go ahead. Let's get the last question.
Okay, I was gonna, Aaron is asking, can you share a bit more about what the participatory aspect of the project involved?
Yeah, so we have 3 autistic community partners that we would work alongside. So me and Aiden were the primary coders. So we first went through all of the data and split it up into independent thought units. And then we had our autistic community partners look over our work. And then in our meetings, we would all discuss just to come to a consensus about how we feel Aiden and I did, because we were still in the learning stages, and their autistic perspective was so important and needed. And then just every step of the way through this process, it kind of echoes the same thing. So Aiden and I were the primary coders, and then they would check over all of the work we did. And then in our meetings, they would give us our feedback or maybe things that we're consistently missing, just so that it's as accurate and representative as we can be. Yeah.
Awesome. And well, thank you both so much. Really appreciate you sharing your work with us. And on that note, we're going to move to the last team. So Alexandra Newson, Dr. Alexandra Newson, I believe, is leading this presentation. And Alexandra, you're, I believe, joined by some other collaborators. So I'll just read them off. Aaron Hopkins, Josh Callahan, Lauren Collier, Heather Brown, Jody Duke, and Liam Whitney. So I'm not sure how many of you are also on this call, but I did want to
have Dr. Jody Duke, Dr. Aaron, I think Aaron's here, Dr. Aaron Hopkins, and Dr. Heather Brown, but I think she has a proxy here today.
Okay. All
And
right.
do I share my screen just to make sure I'm following directions?
Yeah, sure.
Okay.
If you don't mind, and we'll see.
I don't mind at all.
Yeah, and I'll echo Crystal's comment. Nice to see all this research I'm asking. And we can see that perfectly.
Wonderful.
Alex, thank you.
Okay. So our presentation is called Cultivating Community and Empowerment Lessons Learned as Autistic Educators and Researchers. And we have a very large group. Some of them are here today, some of them are not. And I will talk about all of us in a moment. So the overview, we're going to do a quick background on the AIRP Scholars-funded participatory research project, review of how we have translated our research to impact the community, and then a review of our successes and challenges in translating research to impact the autistic community. So a little bit of background. This is an AIRP-funded study titled Double Burnout, Exploring the Experiences of Autistic and Educator Burnout Among Autistic Educators in the United States. This project was guided by the community-based participatory research design framework of Nicolaitis and colleagues, and also used a constructivist philosophy guided by the principles of disability justice, critical disability studies, and the neurodiversity paradigm. We have autistic community partners and autistic and/or neurodivergent researchers and scholars engage in all phases of this research project. So from the very beginning to the creation of what we did, I did have to receive funding, but I myself am autistic, neurodivergent, and disabled, so autistic voice was infused throughout. And then our partners, also known as ACPs, Erin is one of those. I'm so happy that she is here today, as well as the researchers, and were included throughout, and we'll talk about that in a moment as well. We started this project in September 2023. It was my dissertation research project, and we have continued to meet bi-weekly to work on this project. As I think Aiden said, qualitative research takes a hot minute, so we're still working on some of that analysis. So the ACPs, we have 5 autistic community partners from around the United States. Each of them have experience or are actively engaged in educational settings as teachers. Either they're actively teachers in the United States right now, or were teachers. Some of them are in higher education spaces, some of them are in K-12 spaces. All of the ACPs completed the Research 101 trainings from Dr. Jackie Ryan. She created this along with Dr. Sue Fletcher-Watson in the UK, and it's particularly focused on making sure that the research process is accessible and inclusive to all different types of folks. It was created by autistic people for autistic people and includes things like positionality statements, research logistics, ethics, participatory methods, and a lot more. It was 6 sessions, an hour each, and we talked about those things as a group with facilitation from Dr. Jackie Ryan. During that time, we created our positionality statement, which I will state here. We are a team of 5 autistic community partners and 7 autistic, neurodivergent, and disabled researchers and scholars with lived and living experience teaching in K-12 settings. The team is international, with members living across the United States, Canada, and the UK, but all identify as white. As such, the team recognizes that we hold spaces of privilege while also living at the intersections of marginalization due to living within a neuronormative society. Our goal as a team that we created together is to demonstrate inclusive research practices by fundamentally reimagining the roles within research projects to honor and leverage the insights, experiences, and contributions of autistic individuals throughout the research journey. So for question 1, how do we translate research to impact the community? What we are currently doing. When we did our interviews talking with autistic educators, they needed mental health resources to help them with the actual interview process, but also when they were talking about some really personal traumatic things related to autistic burnout and educator burnout. So we created a list tailored to autistic educators that our team curated. And then we also had autistic educators add their own resources. Some of them had their own blogs or had their own activities that they wanted to share. So that is a shareable resource. We also, from our interviews, are creating a list of recommendations to support mental health and well-being of autistic educators, focusing on individual, school, and wider systems. Our team is not about blaming autistic educators for their burnout or for either autistic or educator. We're looking at broader systems of saying, what are the systems doing that make it so it's difficult for autistic educators to be their best selves and to flourish in settings? Over the next 2 years, we are focusing on collaboratively doing professional presentations, publishing manuscripts. We're hoping to maybe create a website with resources if we get really fancy, and then community briefs and infographics. We're trying to make sure that this is accessible not only to academics and researchers, but also to folks within spaces like teachers who don't have a lot of time to work through all the research papers and just need something quick to share with their administrators and share with their districts. Some challenges that we have had in research, translating research to impact community. A big one is delay of funding. This has caused some feelings of frustration, not only for autistic community partners, but for the autistic educators that we are working with. Thankfully, everyone is extremely kind and caring, but when we look at funding, we just need to be aware of that. That's something as a new researcher, as an early career scholar, I didn't realize the logistics of this taking so long. And again, those feelings of frustration, we have a very clear way of thinking about dialogue versus discussion. Dialogue is where we come back and forth without judgment and we have a conversation that's open, where discussion can sometimes be a space of contentiousness and argument. So we have that conversation openly and some expectations about that. And then we work really hard on maintaining and building trust. We are trying our best to have open communication. I have made sure my email is available and meet with folks one-on-one, as well as talking about things that are issues early and frequently and transparently over time. Question 2, successes in translating research to impact community. So we have improved study quality. Our participatory approach has cultivated a collaborative and interactive process that improved our research quality and relevance to our target audience. The involvement of the ACPs has been critical and crucial as they have lived experience with autistic and educator burnout and added to the complexity of K-12 teaching and context-enabled thoughtful study design and deep data analysis. So not only are they looking at it from the perspective of an autistic person, but also that vocational experience is added to the richness of the analysis. We also have successes of impact on team members. ACPs reported gaining new knowledge and skills along experiencing increase in well-being. This was found out through the quality indicator questionnaire that I will talk about in a moment. This is from Morrow and colleagues. I found this resource in the participatory and inclusion guidelines from Australia, and I can share that resource if anyone would like. We also have the Research 101 training, which provided specific knowledge, as I mentioned, and this allowed everyone to have a common language when talking about research. Research is full of acronyms and weird things that most people don't understand. Even researchers as myself don't fully understand. And so when we talk about it openly and allow folks to gain knowledge that they can translate into their own work, whether that be as a teacher doing research in their practice, some of us, like the very new Dr. Hopkins, can translate this work into her future career. Some lessons learned in terms of successes is it's really important to foster accessible meetings that support multiple means of communication so that all ACPs can fully express their ideas. This means we did all of our sessions via Zoom, and so we had chat options, we had reactions, we had folks being able to provide information synchronously and asynchronously. Folks could meet with me one-on-one if they wanted to. Folks could send me a note if they needed to, an email. We also had space to create for formal and informal feedback. So we use the 5-finger feedback, very common in ASPIRE, the Academic Autism Spectrum Partnership in Research and Education. We also use the Stop, Start, Continue method from Hoon and colleagues. And like I mentioned, the Quality Involvement Questionnaire. This was something that we did in November and then in March and compared those scores to see how we are doing in terms of quality of participatory research. Not just that we're doing it, but that it's high quality. We also made sure one of the main things that we learned from that questionnaire is we need to provide explicit descriptions of roles and expectations and make sure that people are aware of that and continue to connect with folks to see if that is aligned with their capacity. As this is a long-term project, sometimes people can have things in their lives that make it harder or easier for them to participate. And we hope that by shedding light on our experiences, as well as our challenges and our successes, that we can pave the way for others to undertake more inclusive and impactful research practices. And thank you. Just a quick note that this project is supported through the HRSA and that this should not be considered as official position policy or endorsement of any said groups. But if you want to contact me, I can, here's my email and I will share that information with our team moving forward. Thank you.
Thank you so much, Dr. Newson. Really appreciate it. How exciting to hear sort of the data from this and about all of the tools and strategies that you use to make this as inclusive as possible. So I do have some sort of questions and comments that I can get to, but I want to first open it up to everyone else and see if anyone has some questions or thoughts for Alex.
And also, if any of the folks, Erin, Jody, if you want to add anything, please feel free to do so. You can do so in the chat, or you can unmute yourself. I would love, it was an Alex show just for a moment, but I just want to reiterate that this is a group participatory project. I was the one who was available today to give this presentation, but this is something that could not be done without the team. So I'll give space for them before I answer the question in the chat.
Sounds good.
Okay, I'm a special education teacher by training, so I provide wait time. It's a hard habit to kick. So Evan, the 5-finger feedback. Yeah. So if you go to the Spire website, they have a beautiful graphic, but basically it means is that when we come up to a major decision in our group, the folks are allowed to either visually, like with their actual hands, or I usually do a poll on Zoom to let us know whether they like that said decision. So 5 fingers means like, yes, I'm totally for this. 1 means we are not doing this at all. And then the 3 means like, maybe we need more information. 4 is like, I'm okay with it, but I'm not like super excited. And 2 is like, again, I need more information. And that's very clearly stated. We came up as a group for what that means. And so if a decision around analysis or about dissemination, we always have that poll, and then I look to see if there's mostly 4 and 5s, that means it can move forward. If we see 3s and 2s or 1s, that means we need to stop, have a discussion or dialogue about said decision, and then come back and vote again. So just a way to gather feedback in a fairly informal way to allow folks to be able to vote on any major decisions that are happening in our group.
Thanks, Dr. Newsom. I'll give another pause here for any of your team members to join in, and anyone else to think of questions. Otherwise, I'll ask my next couple. Okay, so something that's been on my mind as you were presenting, Alex, having gotten into this type of participatory work myself in the last several years, I hear you regarding how time and resource intensive it is. And you gave some really wonderful examples of the specific tools and strategies that you used. The consensus methods, like the one we just mentioned, the assessing the quality of the participatory research, the multiple means of communication. And I imagine that can also potentially lead to burnout. And I was wondering if you could just sort of speak to how you and your team navigated that as sort of a neurodiverse team, in terms of sort of prioritizing that inclusive, authentic participation, and also just being mindful that like we're all humans and we have limited bandwidth. Do you have any sort of thoughts?
That's such a great question, Clive. I so appreciated you asked it. One thing that we said over and over, and I said, is this is a project on burnout. No one can burn out during our project. It would be too much for me as a team member. And what we did a lot was, so every meeting we needed to check in to see how folks were feeling. This was around self-care, around the one we did most recently that I so appreciated Erin's response was around like, what household item would you be? Like very random. We tried to make them more concrete about like, what self-care strategy are you doing? What is a rosebud thorn that you're doing? So really connect with folks before we start the meeting. Another thing that we do is folks can not be at the meeting if they don't want to. You do not need to provide an explanation for why you're not attending. You just need to let me know, and then I will check in with you to ensure that you are well. That's what it's about. I'm not taking attendance to, make sure that folks are being there. It's about, do you want to be there? And I also ask folks about their capacity fairly frequently. So we have side meetings that we can do. Like this is a side project that some folks would like to attend if you have the capacity. And if you don't, participation does not equal passion for a project. So if folks are able to attend a little bit, they are still included in our group. If folks are able to participate a lot, they are still included in our group. In terms of myself, I have wonderful mentors like Dr. Jody Duke, who did constant checking in with me to be like, how's it going? What are we doing? Are you okay? We also meet bi-weekly, but there are times where we canceled it because there wasn't really anything to talk about that day. Like I needed time to look at analysis, or it was a holiday somewhere, or, I got a lot of I can't come because of those things. And that is totally fine. We also had made sure that in terms of cognitive load, I, a week before each meeting, sent the agenda as well as all material so folks could easily have access to that, and then send a summary with a transcript and video. So if people couldn't attend in person because that would lead to burnout and that is above their spoons for the day, they could just attend that way and participate asynchronously. So folks could attend and just like add a little note. Meeting notes were taken diligently around major decisions. Some of those decisions were also made via email. So we're trying our best to ensure that folks, no matter where they are in space, could do that. I also did project check-ins with everybody if they were interested, and just ask them like, how are you feeling about this project? What can I do to better facilitate your engagement? Are you still interested? Because they were not getting compensated, friends. So they were doing this out of the goodness of their beautiful, wonderful hearts. And so I wanted to make sure that whatever I could do to ensure that they were fully able to be a part of this. I think it also helps that we're all neurodivergent disabled. And so you don't have to show up with your video on. If you don't want to participate that much, that's great. No one's going to be like, hey, Erin, why aren't you participating? It's more just like, I care about you. I hope you're well. So that shared understanding was also really helpful. And I was very transparent on days. There are times where at the end of the day, my words were not wording, and I would have to share like, hey, everyone, today's just not a word day. And I have lovely team members who would correct what I wrote when I wrote things wrong, who helped me write notes when I just couldn't do things. So it was a team effort.
Oh, beautiful. Thank you so much for sharing that. And I was just jotting down some ideas, or not ideas, some notes of what you said to make sure I capture that for the future. So thank you so much.
Can I add to her answer? Do we have a minute?
Yes, please.
Oh, 1 minute. I'll be really fast. I think what Alex is not mentioning, because she's modest, but Erin, I think I assume you have the same thought, which is that Alex is an incredibly skilled facilitator. She's so organized. And so that took the cognitive load off of all of us. And she built breaks in, and she really utilized universal design for learning through every single opportunity. And so I think a lot of it depends on the manner in which you facilitate this kind of research in terms of setting those norms, but also being highly organized and making sure that we could literally just show up, give our input and feedback, and move on to the next thing, which I think was incredibly helpful.
Thank you so much for sharing that. Yeah, amazing work, Alex and team. All right, looks like we're being summoned back to the main session. So thank you all for joining this. Really appreciate you sharing your work and your thoughts. All right, see you in a minute. Bye.
Great. Thanks, everybody. Thanks, Calliope.
Thank you.